Every Woman, Every Newborn, Everywhere series on strengthening commodity ecosystems for maternal and newborn health. The series is brought to us by Unitaid and the Concept Foundation in partnership with EWENE. I am Spring Gombe, and I will be moderating today's session, in which our theme will be aligning resources with results, sustainable financing for maternal and newborn health products. I'm very pleased and privileged to be joined by 5 experts for today's discussion. Together, we will look at how financing, from domestic budgets to insurance levies, blended instruments, and procurement-linked tools, can be aligned so that women and newborns reliably get the products they need. I will introduce our experts as they speak. Before I do, some housekeeping. You will see that we have providing English-French simultaneous interpretation. Please follow the instructions on the slide in front of you in order to access interpretation in your preferred language. For any questions, please use the Q&A function that has been activated throughout. Our team behind the scenes will be tracking the questions, answering them online if need be, or directing them, and we will take some of the questions in the final segment. We apologize in advance that we can't take all questions, but we have limited time. We'll do the best that we can do in the time available. Captions are available to all of you, and a recording and materials from this meeting will be shared afterwards. If you experience any technical issues, please use the chat function to flag to our backroom team. So now, assuming that everybody is listening in the channel in the language of their preference, I am pleased to invite our EWENE Management Committee co-chair, Ayman Abdul Mohsen, to set the scene for the discussion on why sustainable financing sits at the heart of a resilient maternal and newborn health commodity system. Over to you, Ayman.
Thank you very much, Spring, and a very good morning, afternoon, and evening to all colleagues and friends who are attending this webinar. I really would like to start by appreciating the hosts of the Health Products Working Group who are co-organized this with Unitaid and the Concept Foundation. And I think we all are very much aware that we are currently at a critical crossroad. M&H financing is currently fragmented and under-prioritized, and we are facing extreme pressure as funding for other health commodities is fluctuating and priorities are competing. So we need to be very much mindful of the environment and the situation that we're going through. In today's session, Aligning Resources and Results, we're going to focus on how we can ensure and maintain that life-saving products are consistently financed, procured, and available where they are needed the most. It is very important that we make sure that these life-saving commodities make it to the end user. So to just touch on some practical points, I'm sure you all agree and you're all aware that EWENE, the EWENE partnership, is not only about theory. We need to focus and continue focusing on navigating financing pathways and aligning procurement systems and improving transparency so we can be able to deliver these essential health commodities. We need to look into the M&H commodities not as a cost, but a smart investment. I'm sure that you all are aware and you all are very much sharing the face that the best investment ever is to make sure that every pregnancy is wanted and every childbirth is healthy and live. And we are not only contributing to preventing maternal deaths, we are also contributing to improving the quality of lives of women and children that we are serving. So it is a very important for us to understand that this is a smart investment that reduces, not that it has its returns in reducing systems-wide complications and builds on long-term resistance. We need to be aware that there is a gap that unlike vertical programs for HIV and malaria, MNH lacks a coordinated global financing mechanism. And sometimes it is subdued under the big ticket items that we all are trying to work through. We face the perfect storm of weak market coordination, regulatory hurdles, and a heavy reliance on limited domestic budgets, which often forces family to pay high out-of-pocket costs. And this is something that's going to be visible and even more challenging with the ODA funding being reduced and the fact that many donors are thinking twice in terms of their investments in maternal health commodities. At UNFPA, we are fully committed to the Pathway Access Framework. And I give you an example. Between 2021 and 2025, UNFPA procured over $101.4 million in MNH commodities. We have just released the Start With Her report, and it shows, and I ask my colleagues to provide it to our webinar attendants. It shows how we have been working to ensure equitable access to quality assured maternal health commodities, and how this has significantly and continues to significantly contribute to saving lives, improving the quality of women's health. Last but not least, we also have multiple financing instruments and tools that by putting them into action, we've been significantly contributing to improving domestic resource allocation and enabling our member states and governments to procure quality assured maternal and newborn health commodities. An example of which we have the globally pooled procurement mechanism and our third-party procurement services that was able to achieve savings of around 73% of the cost of these global health commodities. So today we need to move from abstract to action, and we need to work together in making sure that sustainable financing is there, and it makes sure that what works in practice is what's going to be actually saving lives. We are here to learn about how countries are mobilizing domestic resources, how we can scale these efforts through stronger coordination and political prioritization. Again, I thank you very much for joining, and I thank Unitaid and our moderator and the Concept Foundation for hosting this webinar. And I look forward to a very fruitful discussion. I will give the floor back to our moderator now. So over to you, Spring.
Thank you very much, Ayman. And for our audience, you have heard the perspective from the EWENE committee and from all of us who are working to create an environment where a coordinated global mechanism can be established. We also asked you, because we want this to be a dynamic discussion, as Ayman has pointed out, before we started this webinar, to bring your perspectives in on what is currently missing in lateral newborn health product financing. And as you can see, very large there is accountability, supply continuity, and partnerships. So there is work to be done in those domains. It'll be interesting to unpack, especially for accountability, what we mean and who we're talking about, who is accountable for what at what level. Some of the points that Ayman raised, such as political will, sustainability, and coordination, do not seem to be as high priority among you in the audience. And so it'll be interesting also to unpack those. And I hope that during the panel discussion, both our experts and your questions will help us understand why these dimensions are seen the way they are. For now, I'd like to hand over to Sarah Webb, who is Director of Advocacy, Market Development, and Financing at the Reproductive Health Supplies Coalition, to ground us further in the financing landscape, to help us understand why it is distinct from family planning and broader reproductive health budgets, and what shifts in global health financing that Ayman alluded to mean for maternal and newborn health. Finally, what the evidence tells us about the return on investment in maternal and newborn health commodities. Sarah, over to you.
Thank you so much, Spring, and thank you to the EWENE Health Products Working Group for inviting me to this important conversation. Our session today will focus on the M&H product financing, diagnosing current challenges within the financing landscape, articulating the return on investment for investing in these products, contextualizing challenges within domestic financing, and of course, exploring evidence and opportunities for the path ahead. But before we do that, it's also important to acknowledge that financing for M&H products does not happen in a vacuum. It relies on a much larger system. It relies on a health financing system that has sufficient resources to allocate across health areas. It relies on political will, as we just heard from Spring, to fund the supplies and services needed to deliver quality M&H care. And it relies on data visibility to make informed decisions. It also relies on a functioning supply chain, one where quantification and supply planning accurately reflect a country's need and demand, where procurement is timely and predictable, and where infrastructure is in place to move supplies from point A to point B. Right now, we are facing a crisis for financing for maternal and newborn health. Correcting this crisis and ensuring sufficient resource envelope for maternal and newborn health products and services to deliver them will not only require multi-sectoral collective action, but also an understanding of why the current financing landscape is failing women and newborns. First, and as Ayman just spoke to, the financing crisis for maternal newborn health products is happening against a backdrop of significant reductions to global assistance in recent years. Estimates for 2025 anticipated a 49% reduction in foreign assistance, specifically for maternal and newborn health in 2025. Not only do these trends mean that there are significant reductions in donor funding available for maternal and newborn health, they also significantly restrict the fiscal space that countries have access to. As LMICs are tasked with absorbing more and more of their health systems financing as a whole, they are forced with making difficult decisions about what to fund. And while many donor funding mechanisms remain for maternal newborn health products, like UNFPA, like GFF, and other mechanisms, they often include co-financing commitments from country governments, which require navigating that fiscal space. Second, this challenge is further complicated by funding systems that are often fragmented or siloed, limiting the extent to which health systems can effectively budget for a full package of maternal newborn health products and support integrated person-centered care. Third, the supply chains that deliver M&H products are often inefficient, further constrained by poor infrastructure, delays in receiving donor funding, or disruptions from declining donor funding. This means that even when financial resources are available, the products don't always get to those who need them most. These financial constraints, combined with a more decentralized procurement, can also result in challenges with the quality of products that are procured. Fourth, in most contexts, domestic resource mobilization has not been sufficient in meeting the need for maternal newborn health products and services. These products are often seen as more expensive, particularly when they're packaged with the cost of service delivery. And they further suffer from a lack of dedicated budget lines, specifically for maternal newborn health products, a challenge that can be even further exacerbated by a lack of political will or prioritization of maternal newborn health within a much larger set of health budget decisions. Fifth, data visibility limitations can make it difficult for countries to make evidence-backed decisions. These data systems are often donor-funded, resulting in fragmentation when donor funding lags. Countries also face challenges in effectively leveraging data for supply planning or quantification, and then effectively translating those needs into budget requests. A lack of robust data also complicates efforts to hold governments and donors accountable to commitments that they have made to maternal newborn health, which is further exacerbated by a lack of data that effectively measures health outcomes. And finally, even when maternal newborn health products are available, they are often cost prohibitive due to high out-of-pocket costs, resulting in both an affordability barrier as well as an equity gap. Next slide. Yet we know that investment in maternal and newborn health products saves lives. When maternal and newborn health products and the systems to deliver them are adequately funded, millions of lives can be saved. Estimates suggest that the scale-up of 13 priority M&H commodities could save 6 million lives over just 5 years. When mothers and newborns have access to life-saving health products they need, we can effectively prevent a range of emergency complications, act quickly to treat them when they do arise, and reduce long-term disability or morbidity. But the benefit doesn't stop there. In addition to saving lives, investment in M&H products also saves money. Preventing pregnancy complications reduces emergency referrals, tertiary cost care, long-term disability, and overall system strain. It also reduces disease burden, creating a ripple effect of cost savings to other health areas. Recent global estimates indicate that an investment in basic emergency obstetric and newborn care would return $61.5 worth of benefits for every dollar invested. Other analyses place this number even higher when factoring in things like economic productivity and other economic and social costs. Take Zambia, for example. In Lusaka, procurement and implementation of key maternal health products reduced referrals from 47% to 13%, demonstrating the economic and systems-wide savings of having the right products in place. In Sierra Leone, the Ministry of Health developed a national roadmap to scale up the use of heat-stable carbetocin and tranexamic acid and secured a Catalytic Opportunity Fund grant to roll out the coverage of these two medicines. Currently, all districts in the country have been trained, and Sierra Leone has sufficient HSC and TXA to cover all deliveries annually. Next slide. So what needs to happen to move towards a more sustainable, effective, and coordinated approach for maternal newborn product financing? First, we need to better support country decision makers to take greater ownership of M&H product financing, procurement, and supply chain systems management, equipping them with the tools and resources they need, and ensuring that financing efforts are reflective of both national supply plans as well as country-level priorities, regardless of whether the resources are coming internally from within the country or from global donors. Domestic financing currently faces a range of different challenges. In many contexts, the health system as a whole suffers from limited fiscal space and insufficient health budget. There is a need to grow that total pool of resources, not just for maternal newborn health, but for health as a whole. This will not only ensure that trade-offs between different health areas don't drive financial decision-making, but also that resource allocations to maternal newborn health are more sustainable. There is also a need to strengthen the different financial systems. In many contexts, domestic financing faces challenges with delayed budget release, unpredictable disbursement, and weak public financial management systems. These issues are only further compounded by misalignment with global financing mechanisms or delays in donor funding. And as a result, the outcome is often inequitable, hitting the most vulnerable populations the hardest. Most LMICs do also have a range of financing mechanisms that they can leverage to fill the gap between what country governments can allocate vis-a-vis what is needed in country. For these to work effectively, countries need to be able to pair them with domestic financing approaches in order to bridge gaps in funding. Yet they often face barriers in leveraging these mechanisms most effectively due to limited awareness of eligibility, lack of clarity around the products that are covered, or importantly, the best way to leverage multiple mechanisms at the same time to get the best return on investment. Next slide. There are a range of different options that we have ahead of us and a growing body of evidence to support our pathway forward. First, there's a tremendous opportunity for better sustainable financing approaches, both at the country level via domestic resource mobilization efforts, but also globally through intentional co-financing with donor-funded mechanisms. Second, there are a range of catalytic or blended opportunities intended to strategically catalyze the scale-up and adoption of key M&H products. Third, market-shaping strategies to strengthen maternal newborn health product availability can help overcome market barriers and misaligned supply and demand. And finally, there's opportunity to better engage the private sector as a critical partner in doing this. Regardless of which pathway is best suited for an individual country or subnational context, one thing remains clear. Sustainable maternal newborn health financing is achievable with better alignment, better coordination, and with transparency, and it's strongest with country decision makers in the driver's seat. Next slide. Finally, at the Reproductive Health Supplies Coalition, through a partnership with R4D and in consultation with a wide range of partners, many of whom are on the line with us today, we are developing a comprehensive financing tool aimed at achieving just that: better alignment, better coordination, and better equipping country-level decision makers with the tools, the evidence, and the data that they need to more effectively finance RH supplies. This tool will include 3 important pieces: a mapping of the global financing and co-financing mechanisms in order to fund maternal newborn health supplies, as well as reproductive health supplies more broadly; a component focused on domestic financing and supporting thinking and how different country systems might be able to expand the fiscal space or improve efficiency of public financial management; and finally, advocacy resources that better articulate the return on investment in investing in maternal newborn health and the way that that affects the health systems as a whole. Thank you all so much for being here today and for the opportunity to join you. I'm excited for us to hear from our panel of experts, and Spring, I will hand it back to you.
Thank you very much, Sarah. I will not attempt to summarize all that you have presented, but it is very exciting, especially to see that this new tool is in creation. I believe that will be put in the chat for people to also have access to a link to learn more about it in detail. As you've mentioned, we've got 3 experts joining us to, I think, look at where the rubber hits the road, right? Ayman said, let's not talk about the abstract, let's talk about lived practice in addressing the dimensions of the financial crisis. And my 3 experts are very well placed to do so. They are Claude Kasonka, who is Procurement Services Manager of Financial Sustainability at UNICEF. Welcome, Claude.
Thank you.
Rachel Gyamfi, Claims Manager at the National Health Insurance Authority in Ghana. Welcome, Rachel.
Thank you.
And Buruk Haile, who is the RMNCH lead at PSI in Ethiopia. Welcome, Buruk.
Thank you, Spring.
So I think I'd like to start with you, Claude, and move from, if you like, the global or the multilateral contribution to addressing challenges in financing, to then discussing the domestic realities. And when I think about what is being done at the multilateral level, so much is being led by UNICEF. One of the tools is the Vaccine Independence Initiative. Another is a match funding, both of which have strong track records in immunization. How do you see such tools being used to support country-led initiatives for M&H resource mobilization? What would it take practically to extend these instruments meaningfully to M&H commodities? What should a country check before applying to work with you to use those tools?
Great, thank you. Thank you so much, Spring, and thank you for bringing us together for this important webinar. I think from the UNICEF side, financing of supplies and services try to address some of the bottlenecks that Sarah earlier talked about. Some of these bottlenecks include delayed availability of funds. I think she put that very clearly. She also talked about delayed disbursement of funds, perhaps by the Ministry of Health, and also sometimes poor execution of budgets. But more importantly, also, from our side, it's the technical assistance that is also required to ensure that we address the bottlenecks that currently exist. So you asked me about the VII, or the Vaccine Independence Initiative. So the VII, as the name suggests, is not only for vaccines. It was launched by UNICEF in 1991. It's not a new tool. It's a tool that has been existing for some time and has been tested to work. And initially it was for vaccines, and that's why it's called the VII. But the scope and size of the VII has expanded beyond vaccines. So now it includes all essential commodities. And I'm mentioning this because it becomes particularly important that the VII, to know that the VII now includes maternal, newborn, and commodities that could be made available. So why the VII? The VII, we should look at it as a bridge funding. It is there to address temporary delays in cash disbursements. So we shouldn't be looking at it as a long-term solution. So if a country, for example, is facing cash disbursement problems, the VII can come in and address that. So we can pre-finance so that maybe as the country mobilizes the resources later, they can pay back. But at least we are not having stockouts and we are not having that gap in terms of funding. So it's a bridge temporal financing mechanism that we use to finance a range of products, including maternal, newborn, and child commodities. So it has three mechanisms that we use as part of the VII. One of them is the subscription. We call it the VII subscription. So this is more like a credit line. So a country can come to us if they have, short-term financial gaps, cash problems. We use the subscription methodology as a credit line, so we can advance the country so that they are able to pay for the commodities, so that there are no stockouts and no gaps that are created. But those that do not have a credit line, we have another mechanism which we call the ad hoc, the pre-financing, which is really for those countries that, for example, it's ad hoc. It's something that maybe they don't have an already agreed credit line, but they have these cash flow problems. They can come to us through our country offices and access this facility. Finally, there is also what we call the special contracts. These normally are put in place to accelerate, availability and improved pricing. Because we procure for the globe, we can negotiate for better prices with contractors and also align with country needs and forecasts. So just so that you know, the VII just between 2020 and 2024, we now have new figures for 2025. It grew significantly, and we had a throughput by 2024, between 2020 and 2024, of over $1.7 billion dollars, and more than 100 countries that have been able to access into this fund. So that's the first one. If Spring, you can allow me, the next one that I can quickly highlight are the match funds.
Okay.
We have
Yes.
two mechanisms for the match funds. The first one is what we call the Child Nutrition Match Fund. This is specifically for nutrition products. So the Child Nutrition Fund is really a mechanism that allows us to make the impact bigger. So we go into a country, and if the country, for example, has $1 million, and we also put in a $1 million, together we have $2 million, so that the impact is bigger, and we are addressing those fiscal challenges that the countries face. So by so doing, what we are essentially doing is unlocking the budget for those nutrition products, because some of these are not really budgeted for. And for you to unlock this budget, you really need to ensure that the government is also pushing in something into the funding. And for this fund, we already have more than 24 countries that have subscribed, and for more than $47 million have been utilized for this purpose. The last one, which I won't spend much time on it, is a partnership that we have with UNFPA, which we are calling the MNCH Accelerator. This one is very specific to MNCH product. The difference with the CNF fund is that the CNF fund is more nutrition. The MNCH Accelerator is more on maternal, newborn, and child health products. And these are the products that we are talking about today. So it's a one-to-one match based on dollar value. So like I mentioned, the country brings in 1 million, we push in 1 million, and together we can buy a little more of these maternal newborn facilities. We have a range of products like oxytocin, heat stable cabertostine, and so on that are included in the package for the MNCH accelerator. We also have technical assistance. Now, I spoke about technical assistance earlier. This is a tier that is provided to countries to improve their budgeting, to improve alignment between procurement and budgeting, but also create efficiencies in the PFM and supply chain systems. So I'll end there, Spring, for now, and then I'm happy to take any other questions. Back to you. Thank you.
Thanks very much, Claude. And I'd like to turn over to Brooke and Rachel for sort of the on-the-ground reality check. So Brooke, Rachel, you're hearing Claude describe some tools that sound like they should be very useful for maternal and newborn health. You are both coming from governments that have worked hard to reallocate finances in very fiscally constrained financial settings. Does what Claude is describing, does it speak to you? Is it a useful set of tools? Is there something else that you would like to see? And are you doing different things domestically where you might like to see new kinds of initiatives for which you could get technical assistance from your multilateral partners? Perhaps, Biruk, I'll start with you and then come to you, Rachel.
All right. Thank you so much, Spring and Claude, for the nice presentation. But before going directly to the tools that Claude was mentioning about, I would like to give a brief highlight on how Ethiopia is moving in terms of financing the maternal and newborn health landscape. So as a colleague very close to those programmatic areas, I witnessed that there is a huge, significant commitment towards raising domestic financing in the Ethiopian landscape. So, which is a very promising, honestly speaking, and to see the macro picture, I think even in the last 1 year, the government managed to domestically finance or rose the contribution by close to 43% from the budget last year. So, which is a huge skip or jump towards reaching every newborn and mother wherever they are. So, these are very promising results. And the tools that Claude were mentioning are also part of the exercises as a country. So especially the matching fund exercise was also very helpful, not only from the UNICEF side, but the matching funds are currently being entertained by different donors from different aspects. So especially in the landscape of reproductive, maternal, and newborn health. So initially, the reproductive health sector, especially the family planning section, was a pioneer in exercising those matching funds with UNFPA and other donors as well. So they brought promising results in encouraging domestic resource mobilization every year. So those tools, including the VII, by the way, were very helpful for the country to do continuous access to vaccination as well. As you know, it's not only having the money that will benefit these mothers and newborns. Having the right medicine at the right time, being able to spend the money timely will also be another big question in this discussion. So these tools and initiatives are also very innovative and helpful in that regard. So my biggest fear in terms of this increasing domestic financing is that the current reality shows we will actually acknowledge the overall increment of domestic financing in the country, but when we see like the actual amount of money increasing in Ethiopian currency, which is the Ethiopian birr, that means that doesn't like necessarily guarantee the purchasing power of that money to the maternal and newborn health commodities every year. So we have a severe inflation factor here that will affect the amount of financing increasing every year. So as a decision rule, I will suggest or advocate for prioritizing this increasing domestic financing or funding for especially essential capital expenditures, particularly medicine and supplies, because we need to ensure that these currency shocks, inflation shocks, are not becoming maternal and newborn health shocks as well. So that's one of the things to have a closer look at. The other important key player in the Ethiopian context, even beyond to other countries, is successes in sustainable financing. So for for Ethiopian context, the ultimate success will be like in ensuring the community-based health insurance schemes. Not only that, the overall health insurance scheme is taking the ground very well. So overall, in terms of the community-based health insurance, the country has managed to reach closer to 90% of districts this year, which is a huge achievement. By the way, Ethiopia is, as you know, the second populous country in Africa. We have like close to 1,200 districts in the country and large number of population. But reaching this percentage in CBHI or community-based health insurance is a very promising start, I would say, despite the drawbacks that it has. While the enrollment is very high in encouraging people to be part of this scheme, the stock out rate of commodities in health facilities, the timely reimbursement of funds to those health facilities is a critical challenge. And it's creating like low user satisfaction as well. Despite all those challenges, I think it's a very promising, sustainable way of financing for the country. In addition to that, we have a recently launched social health insurance scheme as well, which is just launched in January 2026, which will also expect to support the overall domestic financing in that regard. So having said that, as another important thing I want to raise.
Let me just bring Rachel in now to also reflect on the Ghanaian experience, and then we'll come back to the additional examples from Ethiopia. So Rachel, having listened to Brooke and Claude, reflect for us on the Ghanaian experience. I mean, you have been very successful in bringing in a national health insurance levy. How does that tie into support from the multilateral level? And are there deficiencies that you see, such as some of the ones that Biruk has mentioned on timeliness and on user satisfaction?
Yeah, thank you very much, Spring. Before I go on, I'd just like to clarify that my role as the National Health Insurance Authority is a strategic health purchasing manager and not a claims manager. So just by way of clarification. Yeah, so Spring, as you mentioned rightly, Ghana has the National Health Insurance Levy, which is a 2.5% consumption tax, tax on all goods and services. And it funds about 75% of the services of the National Health Insurance Scheme. And it kind of provides a predictable domestic revenue stream that is pooled to finance general health services. And then within that package of health services, we have the maternal and newborn care services. So there is a basket of health services, and within that is the maternal and newborn care services. And what it delivers in practice is antenatal care, basic labs and investigations, pregnancy-related complications, medications that are used to prevent and manage these complications, like the iron, folic acid, magnesium sulfates, antihypertensives, oxytocin, etc. Deliveries and complications are also in this package, management of these complications. Then we have the postnatal care for mother and baby, all within this maternal and newborn care package. This package is available to all pregnant women, and it's available across the levels of care. So from the lowest level, which is the community based facilities all the way to the tertiary facilities. And it's also across ownerships. So we have private hospitals or private facilities, public facilities, as well as faith-based facilities, rendering free services to these maternal pregnant mothers, sorry. And so there is that wide range of access when it comes to ownership and then locations of facilities. I'd also like to point that there is an avenue for this package or this benefit to be updated or revised to include new services and medications as evidence points to what needs to be used and the like. So the package is not static. Now there are some challenges, as Biruk mentioned. So in Ghana, aside the NHIS policy, there are also some key system components that run together to ensure that the financing or mobilization reflects the product availability at the point of care. There is the standard treatment guidelines that recommends how conditions should be managed. Then the NHIS tariff that determines what services should be paid for and at what price. And then finally, the procurement reality of real market prices of these commodities. Now, the misalignments between these three components kind of breaks the line between the levy or the resource mobilization against consistent availability of the products at the facility level. And the second point is the level of care limitation. So even though I mentioned earlier that the service is available at all levels, there is a service package for each level. So there are some medications I've mentioned which are useful for the mothers, but are not available for the provider to use at some of the lower levels. For example, you have magnesium sulfate being available in the package, but it's not reimbursable when it's prescribed or dispensed at the very lower level of care. And unfortunately, these lower level of care are mostly the first point of contact for these patients. So it kind of creates some gaps between financing or coverage and accessibility. And finally, as Biruk mentioned, is the delays in reimbursement. So we are supposed to reimburse you as you take care of the patients. But unfortunately, the reimbursement delays and it affects provider cash flow, which in turn impacts the availability to procure and maintain adequate stock levels of these commodities. So overall, the issue is not with the domestic mobilization, but that break between policy frameworks, financing mechanism, and the systems or the supply systems. So back to what Claude mentioned about the match funding and all that. The NHIS, even though has these maternal and newborn health commodities and services within the benefits package, not all of these services or not all of these commodities are covered. So there are some that are not covered. So NHIS covers family planning, but it only covers family planning services. So the commodities are not covered under the scheme. And that is where such a match funding come in to complement the efforts the health insurance scheme is doing now, as well as capacity building at the lower levels of care. Now we have new products, new services coming in, and the providers at the lowest level particularly need to be aware of what these medications are, when and how to administer them and all that. So yeah, capacity building is also needed, but normally there is that gap there. So such match funding and financing sources can help bridge that gap. Yeah, thank you very much.
Thanks very much, Rachel. Claude, can I bring you back in? Because Biruk and Rachel have pointed out something that seems like it's on a continuum. If there's a cash flow problem, the service providers cannot maintain stock. They cannot provide the quality of service that people are looking for. There's low user satisfaction as a consequence. And really the gaps are in the governmental or the domestic capacity to mobilize resources to make up for those commodity gaps. So where do you see tools and instruments such as you provide supporting what they are identifying as problems?
Thank you so much, Spring, and thank you, colleagues, for bringing up these issues. Let me talk about something maybe I didn't touch on very clearly from the onset. The technical assistance that we provide to government. There is a tool that we have developed as UNICEF, and it's called the Efficiency Savings Tool. What that does is to go into analysis of where value for money is in the procurement or supply chain system. But more importantly, it's also about making use of what we have better. Because I think the narrative has been, we need more money, we need more money, we need to reach the 15% Abuja declaration. Now the narrative needs to shift to how can we make use of the best available resources and create the fiscal space that we talk about. So I think for me, those are the touch points that will help us improve both from the supply chain system perspective, but also the PFM. Then I also want to mention that any financing tool, whether it's matching, whether it's bridge funding, whether it's debt swaps, any of the tools that you can mention hinge on stronger PFM systems. We need to have stronger public financial management systems in order to properly anchor these different tools. Without that, there are leakages in the system. There's a lot of misappropriation of funds in the system because of weaker PFM systems. Finally, I want to talk about the end-to-end supply chain. I think that is very important, how we ensure that we are tracking, these commodities properly up to the end user. I think that there is quite a lot that has been done, but more can be done in this space to plug those leakages that we see in the system. So that's my reflection, Spring, about how we can address both supply chain procurement, but also PFM systems.
Thanks, Claude. Biruk, I saw you nodding, so I will come back to you to underline those points at which you agree with Claude, but also to raise some of the other issues that you were about to do, and to perhaps flag for us where you make trade-offs and how you make the decisions about where those trade-offs are to be made.
Yeah, thank you so much, Spring. I was nodding because Claude touched some point that I do agree on, which is about being efficient enough with what we have on the hand. So I do agree mostly on that insight and reflection, but I also agree that pushing countries to reach to the Abuja Declaration is also a thing that we should do parallelly. So we have lots of work to do in terms of increasing the financing for MNH. That's my strong stance in many ways. The other thing that I wanted to highlight earlier, beyond the challenge of the inflation of our currency and in many African countries, the other emerging challenge is like the aid fungibility. I don't know how much of you know about that word, but there is the aid paradox and substitution risk, which relates to that the recently increasing foreign aid towards financing these MNH commodities, which is a reality in Ethiopia. I'm sure it's also shared in many countries across the world. So there is a huge amount of money pulling towards the maternal and newborn health financing from foreign aid, which is a very good thing. It will save the lives of many mothers and newborns, at least temporarily. But my fear here is that external assistance might have the chance to crowd out domestic responsibility. You see, governments have always priorities to look up to. Health is not only the only priority they have. So what my fear is like in the near future, they might completely start to go more dependent on foreign aid and start declining the domestic allocation of budget. So that's my fear. So far, we're good enough in terms of that, but we need to push as well that if foreign aid has to be used, it should not be a replacement of treasury funds rather than a supplement. So the achievement in domestic finances will be drawbacked otherwise if we are not still going to advocate for those as well. So as a conclusion, I think we have built a stronger domestic financing architecture in the country, especially in Ethiopia. And the increased domestic financing is also very promising, honestly speaking. But what I strongly believe is that we must protect these gains from inflation and aid dependency as well, because we're talking about sustainable financing of maternal and newborn health commodities. So these are the remarks that I wanted to make. Thank you, Spring.
Thank you very much, Biruk. I mean, the discussion about what's happening in the architecture is a very big and deep one that could preoccupy us for a very long time. Rachel, maybe I wanted to take also your final observations on this. Do you share these concerns about inflationary shock to the CD, for example, the strong political will and then investment in a national instrument that sort of creates room for Ghana, that could be threatened, and what are you looking at to protect that in the near and maybe middle future?
Okay, thank you very much, Spring. Rightly, inflation affects everything and everyone. So the NHIA has a policy framework that guides the annual review of our tariffs, as in what we are paying for and how much we're paying. And unfortunately, first of all, there is a gap in that annual reviews. But then secondly, you could also do the reviews today or this month, and within 6 months, inflation and exchange rates have changed. And so even though you have reviewed it to reflect market prices today, within 3 or 4 months, the tariffs do not match the market realistic cost of commodities. So yes, it definitely affects us in a way, in a very profound way. I would like to touch on the trade-off in Ghana. So with us, the trade-off in the context of the NHIA is that the tax or the levy is not earmarked for maternal and newborn health. It supports a broader scheme of health services. So the trade-off here will be less about earmarking for maternal and newborn health versus some kind of flexibility, but about how we prioritize maternal and newborn health within the already earmarked health financing pool. So I mentioned earlier that there is that room and avenue for us to review our benefits to include new services and new commodities. And so there is that flexibility within the earmark tax to accommodate new services and maternal and newborn health commodities. So it is the prioritization is more at the purchasing level and not at the revenue mobilization level. Yeah, so that would be my final submission.
Thanks very much. I have loads of other questions that I would like to ask, but I thought we promised the audience to bring them in. And so maybe let me try and do that at this stage. We have a question here which may be directed to you as well, Sarah, and the new comprehensive financing tool. But I'm happy for anyone who wishes to take it. The question comes from Jeffrey Jacobs. And the question is, what is the role of cost effectiveness analyses across and comparing maternal and newborn health interventions in strengthening financial allocation of limited resources? Don't know who wants to take that. Maybe just come in if you wish.
Yeah, I can. Go ahead. You go first.
Rachel and then Sarah. Go ahead.
Right, sure. So I keep mentioning that there is that avenue for adding on to our benefits. But before we do, yes, we conduct all these cost effectiveness analysis, budget impact analysis to determine if it is good to invest in such a commodity, what are the returns of investment in the long term and all that. So yeah, within the operationalization and within the guidelines where we follow to add on a benefit, whether a service or a commodity, we definitely conduct some kind of cost effectiveness analysis, budget impact analysis, and then returns on investment analysis to decide. So it's actually evidence-based and not an ad hoc addition to the benefits. Yeah, thank you.
Thanks very much. Sarah.
Yeah, thank you. And apologies for background noise. I'm at a very timely meeting of the World Bank spring meetings this week and headed to a financing event on maternal newborn health. I was just going to add, I think cost effectiveness is critical. And I think that it would be really helpful kind of coming back to this theme on alignment and coordination to align as a community around sort of a framework and methodology that we want to use for cost effectiveness, because so many of the initial analyses that have been done on this look either purely at the commodity or purely at a certain service delivery approach. And I think being really intentional about thinking about the much broader ecosystem required to both procure that product, to store and warehouse the product, and then also to get that product from point A to point B, all factors into that cost effectiveness analysis. And it will vary from different context to different contexts. So really kind of aligning around an approach that can then enable that type of comparison would be absolutely critical. And I think it's a great point, and something that would be great to see some community alignment around. Thank you, Spring.
Thanks very much. And hopefully we didn't disrupt too much your walkover. Biruk or Claude, do you want to come in on this point? And if not, I have a question directed at you, Biruk.
Yes, so I think the question is related to the yeah, I don't know if I understand the question very well, but the overall support that we're having or the recently signed agreements as a country are very promising, honestly speaking. So my biggest experience in terms of like the mobilizing large amount of money at the same time in recent years is especially this year. So there are lots of supports coming to the country. So that's a very good starting point. At least we will have like some relief in terms of reaching out the backlog of reimbursement issues in maternal and newborn health. I'm sure by now you understand that the maternal and newborn health services are being given exempted from fee in Ethiopia. So we have a large number of population in terms of the child age group and the pregnant mothers. So every year, close to 4 million mothers or women become pregnant in our country. So that's a large amount of population. So the demand for those supplies, commodities, and medicine is very high. So it will give a relief and an opportunity to breathe for us to further use this as a springboard to mobilize more resources from other aspects as well. So these recent agreements are very promising, even so some of them are controversial. So my fear here is that as the government has lots of priorities, this foreign aid increment might expose us to the aid fungibility or reduction in the domestic financing, maybe in the coming years. So hopefully it won't happen. That's my expectation, Spring.
Thank you very much, Biruk. Claude, do you want to come in?
Yeah, I just wanted to add. I know that I've seen chats in the comment section that colleagues are already asking for the efficiency savings too. This is something that we are piloting, and it also hinges on cost effectiveness, because that's the whole point of doing what we are doing, is to see where we can get value for money. And that's the first stage in the process, identifying the value for money agenda, and then you go into the nitty-gritties of what are the issues, how can we address them. If, for example, you were to change your procurement methods, what benefits would that accrue in quantitative terms to the country? And oftentimes it's millions millions of dollars. So yes, we are piloting this tool right now. We've done 2 countries. We are now doing the 3rd one because we want to get the experience also from West Africa, because the first 2 were in Southern Africa. And then we will compile the final 2 that can then be shared for review. So that's what I wanted to mention on the efficiency savings. It also hinges on cost effectiveness. I should also mention that cost effectiveness analysis is good only when the results are applied in country, because we've seen a lot of these investment cases, cost effectiveness analysis that end up gathering dust. I'm sorry to say, but that's the reality. But if it's grounded into the national system and owned by, the government and national systems, then it sees implementation at the end of the day.
Thank you very much all for your contributions. There are additional questions in the chat, which perhaps you could address by typing your responses in as we are at the top of the hour. It has been such a fascinating discussion, and I think from the number of questions I see, folks would like to continue to have discussion around this matter, and perhaps even have a discussion around the tool in more detail once it has been piloted and is available. We touched on the need for alignment on aid fungibility, on cost effectiveness, on political commitments to the 15% Abuja target, on fiscal space, on finding that balance between supporting domestic resource mobilization and investment, and then complementing it with the tools that come from external assistance. And that is not an easy balance for countries to manage, and especially not an easy balance when health is one of the priorities that a government has among many, and an easy solution might be to hand things over to external partners so that monies are released for elsewhere. And we know that that would not be to the benefit of maternal and newborn health. This webinar series was designed to close after this first round, but it's so important that we are going to look to extending it further. In this first round, we've explored access, quality, procurement, and sustainable financing as key drivers of maternal and newborn health. They shape not only the availability of life-saving commodities, but also, importantly, quality, affordability, and sustained use within sustainable health systems. Thank you all very much for sharing your expertise with us. We look forward to continuing to grow this community of practice and the exchange around it. Thank you to our audience for your very interesting questions and for your continued commitment to the discussion from webinar to webinar. Perhaps I can turn back over to our EWENE hosts for a final word, and otherwise we will close. Okay, so I don't see them come in. So thank you again, everybody, and wishing you a pleasant rest of the day and week. Thank you. Bye-bye.
Thank you very much, everyone.
Thank you.
Bye.
Thank you, Spring, for the excellent moderation.